Now it gives me great pleasure to introduce Dr. Wolfgang Kohler. Again, Dr. Kohler has really supported us in so many ways over the years. He's done so much research and supported so many families. So it's lovely to have him here with us today. And he's going to tell you about new data on cerebral adrenoleukodystrophy.
Yeah, thank you, Karen, very much for inviting me. I'm so happy to be here for many years now and to discuss some new data on cerebral ALD with you. So, see, looking at ALD, we see such a variety of clinical presentations from early, little bit of neurological symptoms, walking problems, bladder dysfunction, over a lot of myelopathic symptoms like severe gait disturbances, severe bladder bowel dysfunction, sexual dysfunction, up to some cerebral involvement, which is devastating, as we all know. And so we see all these variety of phenotypes. But what is common in all of these phenotypes is a chronic progression of disease, which we also call neurodegeneration. How's that? So there's a progressive neurodegeneration, which is a common sense in all of these clinical presentations of adrenoleukodystrophy. So this is very important to recognize, and this will also impact very much our common thinking on what is adrenoleukodystrophy. So inflammation, in addition, is also a big problem, and we don't know how this happens, that children at a certain age gets inflammation, or adults in various ages get cerebral inflammation, but most likely there are some modifying factors, which I'm coming back to this problem a little bit later in my talk, that is causing inflammation of the brain and cerebral adrenoleukodystrophy. But the basic problem I really want to emphasize is that this disease is an inborn error of metabolism causing a chronic neurodegeneration. Second is that we have a continuous and overlapping spectrum of phenotypes. So it may be not so important just to categorize the patients to a certain category, AMN or adrenoleukodystrophy or cerebral involvement or whatever. So it's a continuous progression of the disease with the underlying neurodegeneration. So when we looked at the brain, for example, in these patients, is there a pointer? Yeah. We saw, even in areas where the MRI looks completely normal, we already see in these areas that there is neurodegeneration. What does it mean? Neurodegeneration is a destruction of neurons, the cells that we are thinking with, the very important brain cells. Here on the right side, you see these brain cells colored in red, and you see these interruptions here of the long axons of these neurons. And we are finding these structural disturbances of neurons already in brain areas that are obviously not involved looking at the MRI. Of course, this is getting, and in addition, in this area where the neurons are already involved in the disease process, the white matter is still intact. So it's not primarily a white matter disease, what we expect from the name leukodystrophy. It's primary neuroaxonal disease. So this is very important to remember, to understand the disease. So we come up with a conclusion in this paper that that acute axonal injury and permanent axonal loss, brain cell loss, is by far underestimated, an underestimated feature of this disease that must come into our focus in our research for biomarkers and novel therapy approaches. Yeah, it will change our view on how we approach therapeutically this disease probably. So, and this opinion is also supported by some biomarker studies that we did together with the group in Vienna, where you can see that certain biomarkers, we already heard about neurofilament light. It's a biomarker, new biomarker, which is indicating a destruction of neurons. So if it is high, then the neurons are going to die and just destruct. So they release this neurofilament light, and you can measure it in the blood. And what we see from these biomarker studies is that there is a clear correlation. The more severe the disease, the higher is this neurofilament light. So this is again an indication that neurodegeneration is an important feature in this disease. So here's some examples. You see a patient developing brain involvement over time, and here you see the elevation, the neurofilament lights going up as soon as there's brain involvement. But most interesting, we also find some other brain involvement patients where this elevation of neurofilament lights is not as much or even not present, and we go back in these patients and look more closely. What is the difference? Why do these patients don't have not this elevation of biomarkers indicating a brain destruction? And we come up with a new characterized cerebral ALD phenotype that is what we call smoldering phenotype, which is lasting much longer than we are usually know from other patients with cerebral involvement. So this was an idea that it's obviously, even if you do have brain involvement, it's not the same disease, or it's not the same phenotype. There's a spectrum, a variation of phenotypes and variation of clinical progression. Even so, both of these patients have cerebral involvement. But one patient is very slow progressing, the other is very quick progressing. And this is important for our treatment decisions, of course. Yeah, as you may know, the patient with a rapid progressive disease needs a completely different strategy to treatment than the one who has very slow progression. And we also can use these biomarkers for a treatment response. As you can see here, that there are two patients who treated with stem cell transplantation, and after transplantation, the neurofilament lights returned back to normal, indicating that the brain destruction is stopped after brain stem cell transplantation. Maybe. So what I want to say is that we also need to use new biomarker for treatment decisions, for the monitoring of treatments, and so on. So coming back to potential risk factors, there's a lot of things under discussion over the years. There are a lot of discussions on modifier genes. Are there some genes other than the genes who are directly involved in the disease pathogenesis, who are important for the clinical progression of the disease, so-called modifier genes? So maybe changing the role of other transporters, ABCD2 for example, or some polymorphisms that are involved in some metabolism of the brain, which is important for getting new white matter, for example, methionine metabolism. So there are a lot of ideas, but none of these really comes in front that it's really the truth. So, but there may be some things important in some other genes that we don't know yet. Of course, there are environmental factors, and it's important for you, for example, not to have some, trying to avoid head trauma, because there is some papers out there. Joe Raymond is here in the room, published a paper, for example, on the effect of a minor head trauma on the onset or progression of cerebral disease. So this may be also important, that there are environmental factors. There are also oxidative stress factors that are that may be important for the progression of the disease. But one factor is really very important, I think, in every patient, which is the metabolic situation. All patients with adrenoleukodystrophy do have the inborn error of metabolism. So they have elevated long-chain fatty acids, which are in higher doses toxic for brain and spinal cord or peripheral nerves. So there are clearly metabolic factors that we need to take into account and to understand that this is important for the progression of the disease. And this is very much supported by very recent work of Stefan Kemp, who is sitting in the room, and Jorik Jaspers and Mark Engelin. We also did some support on this, and also Troy Lund. So it's a lot of people work together on a new technique we call lipidomics. So with this lipidomics measure, you can measure all lipids in body fluids that are present. And what we see, there's a significant increase in various long-chain fatty acids containing lipids in ALD patients with cerebral involvement versus AMN. So there is a clear correlation of this biomarker with the severity of adrenoleukodystrophy. So this means, for all of you having adrenoleukodystrophy, the basic treatment of adrenoleukodystrophy is normalization of long-chain fatty acids. Yeah. We know that already for many years. 20 years ago, we tried to set up a new scoring system for adrenoleukodystrophy and looked at the natural history of, in this case, 50 patients with adrenomyeloneuropathy over a period of 14 years using this score. But when we come up with this graph here showing that there is a linear progression in the natural history, you all know that, which is measurable with the score, even retrospectively, and you can even quantify this score, which there's a mean progression of around 0.5 ACS points. It is the score per year in a patient with an adrenomyeloneuropathy. So, and these 50 patients then were treated with Lorenz's oil in this case, and 45 of the 50 patients succeeded to have completely normalized long-chain fatty acids over up to 13 years. So in a mean duration of 6.3 years. And this period, after treatment, the same patients that without treatment deteriorated continuously before that stopped progression, or nearly stopped progression. There's a little bit of progression over time, but only a little bit. And this is at least a hint that normalization of long-chain fatty acids is really helpful in all patients with adrenoleukodystrophy. So this is something you can do. You can do that, changing your eating habits to a healthy Mediterranean nutrition, and probably add some monounsaturated shorter chain fatty acids to the diet, and you can normalize your long chain fatty acids quickly and very efficiently. So it's something that you really can do, and you can change your life with this. So coming back to the cerebral ALD, so this is really a devastating disease. It's defined as clinical and radiological progression, and you already heard today that it's affecting 30 to 40% of childhood males. But you may not know that in addition, up to 60% of ALD males will get cerebral involvement over time. So in the end, 2/3 of all male patients will get cerebral involvement with this disease. So this is very frequent. Yeah? And we can measure this very easily with MRI, as you know. So the only prerequisite is that you have to go to the MRI on a yearly basis. So I really recommend to do that, to detect a cerebral involvement as early as possible, because it has traumatic consequences. If you just ignore this situation and not monitoring correctly, then it may start with a cerebral involvement and you didn't recognize it, but sometimes it takes only a couple of months until there is a severe progression of the disease, which is not reversible. So this graph here shows you data from many centers in children and adults, and also from our center. These are MRI scores, and when the line is in each dot is an individual patient. So if the dot is going up, the MRI score is getting worse. So they all are cerebral patients. And why I'm showing this is that what you can see here, that there is cerebral ALD can occur at all ages. It's not only restricted to children. It can affect adults at all ages. So you never rest for looking for cerebral involvement, so you have to go to the MRI on a yearly basis. So here's some examples, because I want to also show that this cerebral involvement may occur primarily without any disease before that. So this is a situation that frequently happens in children as well. So they start with a primary involvement of the brain inflammation. And so here, this is a student, completely normal, and then it starts, and 2 years later he had this severe involvement of the brain with complete dementia and severe encephalopathy. So this is the primary cerebral ALD, but more frequently we see a progression of cerebral ALD from AMN. So patients, this patient, for example, started at age 22 with a mild spastic gait ataxia. We had some symptoms already at age 17. So he's a long-term AMN patient. When he then starts many years later, so 10 years later, with an early brain involvement and contrast-enhancing brain changes that are indicating that now something has changed in the disease progression. And then the disease progression is getting much more rapidly once the cerebral involvement occurs. So this is what we call secondary adult cerebral ALD. So just looking at the MRI changes in children on the left side and adults on the right side, that's not a big difference. So once the cerebral involvement occurs, the progression of the disease is very similar in children or in adults. It's rapidly progressive. And also, we know that the MRI progression is very much correlating with clinical scores, for example, with a cognitive score or clinical scores. So what is new that we looked at 60 patients with cerebral involvement in adulthood, and what we see here is that it takes about 27 months, so it's a little bit more than 2 years only, until most of these patients died after onset of cerebral involvement. So it's a rapid progressive. And even if you look at this group more closer, you see two groups of patients. You see high active patients that have a survival time of only 18 months. It's 1.5 years. And there's another group which has much longer survival time. Most likely these are the previously mentioned smoldering phenotype patients with a longer progression of cerebral involvement, more than 5 years. So we have to differentiate these, and we need some biomarkers to differentiate these two groups for our treatment decision. So in summary, I would say there are obviously potential risk factors for getting cerebral ALD, which is, for example, head trauma, but especially high levels of very long-chain fatty acids may influence the onset of cerebral ALD and progression of the disease in general. The onset of CALD may occur at all ages, and this is important for you to know because you need to have an MRI monitoring every year, at least an MRI, optimally in a treatment center for leukodystrophy, where you see the doctor and you can discuss the new results with your doctor who is specialized on leukodystrophies. Most patients with cerebral involvement have a very fast progression with a mean life expectancy of only 18 months. But some patients show a very slow progression with significant longer mean life expectancy around 6 years. So MRI, neurofilaments, very long-chain fatty acids, and potential other biomarkers are very important and useful to predict clinical progression. But in the end, it's not very useful to have fixed phenotypes we are talking about. We need a new classification of cerebral ALD based on clinical and MRI progression rates, which is much more useful for the use in therapeutic decisions. Thank you very much.
Thank you, Wolfgang.